Welcome back to the deep dive. Today, we're embarking on what I think is a really essential mission. We're taking one of the most foundational and, let's be honest, dense chapters in surgical training, Chapter 40 on the knee, from Baily and Love's 28th edition.
And we're going to try and break it down.
Exactly. Break it down into highly memorable, clinically relevant insights. We want to distill the complexity of a joint that is simultaneously brilliant in its function and, you could say, inherently flawed in its design.
I think flawed is the perfect word. And you should think of this deep dive as your advanced cognitive map. We are not, and I want to be clear about this, we're not reading the textbook to you.
No, not that.
We are interpreting it. We're connecting the rigid anatomical facts to the dynamic, often messy world of pathology and surgery. If you're revising for exams, this is your ready reckoner.
The idea is to anchor those vital concepts, the ones that really underpin every decision a surgeon makes in the operating theater, so they stick with you long after you finish listening.
That's the goal.
You know, it's funny, the knee is often just categorized as a complex synovial hinge joint.
Wow.
But when you actually look closely, that description kind of betrays a paradox, doesn't it? It's made of two condyloid tibiofemoral joints and that very unusual sellar or saddle-shaped patellofemoral joint.
And it has to take these massive dynamic loads while somehow staying stable. But structurally, you're absolutely right. It's closer to two highly polished marbles just resting on a tabletop.
An unstable tower.
Exactly. And that paradox is the core concept of the entire chapter, the intrinsic bony configuration. It offers very little stability on its own.
So everything else has to make up for that.
Everything. Stability has to be achieved through robust, layered, external reinforcement. We're talking ligaments, menisci, and muscles. All management of knee pathology, from a simple ACL tear to end-stage arthritis, is just an attempt to manage or repair this inherent structural vulnerability.
Okay, so our goal is clear. We're interpreting the chapter's core learning objectives. We need to lock down the applied anatomy and biomechanics, navigate the clinical presentation and management of common injuries, ACL tears, meniscal rips.
And then critically analyze the current state of joint preservation, replacement, and even salvage surgery.
Right.
And, as always, a fundamental reminder for everyone listening. We are providing the interpretive structure here. For the comprehensive, definitive detail, you must engage with the original Baily and Love text. Use this as the framework to prioritize your reading.
Let's start with that crucial conceptual anchor we mentioned, the unstable tower. If the knee is structurally unstable, what exactly are the systems that hold this heavily loaded tower upright? The source material divides them pretty clearly into passive and active systems.
Yeah, and we call those the static and dynamic stabilizers.
Yeah.
The static stabilizers are, let's call them the passive steel cables that provide the rigid structure and prevent gross translation.
Okay, so that's the ligaments.
That's the joint capsule itself, the menisci, the collateral ligaments, your MCL and LCL, and of course the critical internal cross braces, the cruciate ligaments, the ACL and PCL.
And the dynamic stabilizers. You call them the winches. These must be essential not just for movement, but for that split-second stabilization during, say, sports.
Precisely. That's the musculature, primarily the quadriceps, especially the vastus medialis obliquus for patellar tracking, and of course the hamstrings. They fire dynamically to control rotation and translation during motion. They're basically taking the slack out of the system before the static stabilizers reach their breaking point.
So without good dynamic stability.
Without robust dynamic stability, the static structures are just doomed to fail under stress. It's only a matter of time.
Okay, let's unpack the menisci. They're often oversimplified as just shock absorbers, aren't they? But that fibrocartilaginous structure between the femur and tibia does so much more.
Oh, much more.
So what are the two most critical mechanical roles beyond simple cushioning that really dictate the long-term health of the joint?
Well, they are absolutely vital for increasing the surface area of load dissipation, sometimes by up to 50%, which protects the fragile articular cartilage. But the concept we really need to lock into memory is hoop stress. This is the key clinical nugget.
Hoop stress. Okay, explain that to us in practical terms. What happens when the knee bears weight?
Okay, imagine the menisci are like the metal hoops on a wooden barrel.
Right.
When the knee is loaded, the femurs push down, and that load is converted into circumferential tension in the meniscal fibers, pushing outward. This mechanism effectively spreads that compressive force across the entire tibial plateau.
Ah, so it dissipates the force.
Exactly. Now, if you have a tear specifically, a tear that violates those circumferential fibers, like a radial tear or a root disruption, you defunction the hoop. The stress suddenly becomes concentrated locally, and that protective function is completely lost.
And the consequence?
The consequence, as the source material makes terrifyingly clear, is rapid degenerative change and accelerated arthritis.
So, if a surgeon removes a significant portion of a torn meniscus, meniscectomy, they are essentially signing that joint up for early arthritis because they've eliminated that hoop stress mechanism.
That's exactly why the focus has shifted entirely toward repair whenever possible.
Right.
And, the source material highlights the frequency difference. Medial meniscal tears are 3 times more common than lateral ones.
And why is that? There's an anatomical reason for that, isn't there?
A simple but critical one. The medial meniscus is firmly anchored to the deep layer of the MCL, making it relatively fixed. It's vulnerable to getting trapped under rotational stress. The lateral meniscus, on the other hand, is far more mobile, allowing it to move out of harm's way during twisting motions, hence its lower injury rate.
Fascinating. Okay, moving to the collateral ligaments, the side supports. The medial collateral ligament, the MCL, is broad and flat. It's the primary restraint against valgus stress.
That's a force pushing the knee inward, like a tackle on the outside of the knee. And the MCL has a clinical implication that offers a bit of hope, actually. It's commonly injured, but because of its broad structure and its proximity to the rich surrounding blood supply, it often heals really well with non-operative management.
So bracing and rest.
Bracing, rest, physiotherapy, exactly.
The lateral collateral ligament, the LCL, is a sharp contrast. It's a cord-like structure, the primary restraint against varus stress, so force pushing the knee outward.
And its recovery profile is much less forgiving. The LCL is part of a complex group of structures we call the posterolateral corner, which includes the popliteus tendon and the popliteofibular ligament.
So it's not working in isolation.
Not at all. And injury here is more structurally isolated, and LCL tears are much less likely to heal conservatively. They often require formal surgical reconstruction to restore function. When you see an LCL injury, you have to be suspicious of injury to that entire posterolateral corner complex.
Okay, now for the internal cross braces, the cruciates. The source material emphasizes they're both composed of 2 distinct bundles. Why is that detail so important?
Because this is where we move beyond just simple anterior and posterior restraint. It's about dynamic stability throughout the entire range of motion. The ACL, which prevents anterior translation of the tibia, has an anteromedial bundle and a posterolateral bundle.
And they work at different times.
They work reciprocally. The anteromedial is tightest in flexion, and the posterolateral is tightest in extension.
And the PCL preventing posterior translation, it flips the script.
Yes. The PCL's larger anterolateral bundle is tightest in flexion, while its posteromedial bundle is tightest in extension. This bundle structure ensures that no matter what angle the knee is bent, at least one part of the ligament is taut, providing continuous tension and stability.
So if we're looking at clinical severity, a single ACL tear is usually a sports injury. But when we start seeing multi-ligament injuries, say 2 or more of these 4 static structures are torn, that signals something catastrophic.
Your mind must instantly go to high-energy trauma.
A car crash.
A dashboard injury in a car crash or motorcycle accident. Multi-ligament injuries usually result in a complete joint dislocation, which is a limb-threatening emergency.
And why is that? Why is it so urgent?
Because the trauma required to tear multiple strong ligaments simultaneously often stretches or disrupts the popliteal artery and the common peroneal nerve, which are right behind the knee.
Mm-hmm.
Immediate reduction and vascular assessment are absolutely non-negotiable.
Right. Okay, finally, before we move to motion, let's just revisit the articular cartilage, that specialized hyaline surface. The book delivers a pretty harsh biological reality here.
It does. It is a vascular, lymphatic, and aneural.
No blood, no lymph, no nerves.
And that combination means it lacks the fundamental biological machinery for effective repair. If you scrape it or tear it, the body simply cannot mount a typical inflammatory or healing response. This is why cartilage damage is functionally permanent and why research into cartilage regeneration is one of the most challenging areas in all of orthopedics.
Okay, so let's talk about how this complex machine moves. Kinematics. While the motion is mostly in the sagittal plane, flexion and extension, the book stresses that rotation is critical.
It's absolutely critical, and it increases with knee flexion. The motion isn't a simple hinge motion at all.
So what is it?
It's highly complex, a combined rolling and sliding of the femur on the tibia. The femur initially rolls backward, but if it only rolled, it would quickly just fall off the back of the tibial plateau.
Right, it would dislocate.
So it immediately transitions into sliding forward to maintain contact.
And this movement involves the screw home or unlocking mechanism. This is where the difference in the condyle size comes in, isn't it? The medial femoral condyle is larger.
That's the critical detail. The larger medial condyle rolls back less than the smaller lateral condyle during the final stages of extension. This difference forces the tibia to internally rotate relative to the femur during flexion and externally rotate during extension. It effectively locks the knee in terminal extension for efficient standing.
And what's the typical range of motion?
Typically about 5 degrees of hyperextension, up to about 135 degrees of flexion. Losing that rotation significantly restricts function.
Now, the patella. We called it the leverage multiplier. It's a small bone, but it's mighty. Its role as a pulley seems straightforward, but its biomechanical contribution to the quadriceps power is immense.
It acts to increase the moment arm of the quadriceps tendon. Without the patella, the tendon would sit right against the joint, and that would drastically reduce the effective leverage. The patella moves the line of action further away, improving the mechanical advantage and increasing quadriceps power output by up to 30%.
And the loads this small bone withstands are just staggering. It has the thickest articular cartilage in the body.
It has to. It manages loads up to 20 times body weight when jumping.
20 times. Incredible.
It's a phenomenal force.
Yeah.
And that explains why any slight mechanical imperfection, abnormal Q angle, muscle imbalance, or trochlear dysplasia can cause the patella to track incorrectly. If it pulls laterally or medially, the concentrated stress can lead to patellofemoral pain syndrome or, outright dislocation.
Okay, let's establish the absolute foundation for all surgical planning. The axes of alignment. This is crucial for understanding total knee replacement and osteotomy.
Absolutely. We have to distinguish between the anatomical axis and the mechanical axis.
The anatomical axis is the simple one, right?
It is. It's the simple line down the center of the bones themselves, the medullary canal, the femur, and the tibia. It's easy to measure, but it doesn't represent the true load path.
And the mechanical axis, however, that is the load line.
Correct. That line runs from the center of the hip, so the femoral head, right through the center of the knee, the intercondylar notch, and down to the center of the ankle. This is the path of gravity and weight-bearing force.
And here's the key distinction, the one that requires the valgus cut angle. In the tibia, the anatomical and mechanical axes are coincident, but in the femur, they diverge.
They diverge by about 5 to 7 degrees.
Why?
This divergence exists because the femoral neck offsets the hip joint laterally, which allows the body's center of gravity to fall over the feet. So, to create a knee joint that is perpendicular to the true load line, the mechanical axis, the surgeon has to account for this 5 to 7 degree difference when cutting the femur. This is the valgus cut angle.
And getting that wrong.
Getting it wrong means introducing immediate malalignment and predisposing the implant to early failure. It's that simple.
So if a patient has long-standing varus malalignment, meaning their mechanical axis runs significantly through the medial compartment,
You'll get concentrated pressure, accelerated medial compartment arthritis, and ultimately failure of that compartment. A TKR traditionally aims to restore the leg to a neutral mechanical axis for optimal load distribution across the implant. And realignment procedures like an osteotomy, well, they aim to temporarily shift that load line away from the damaged area.
Okay, it's time for a critical check-in question. Let's say we have a patient who suffers an injury that results in a severe, complex radial tear, and it extends deep into the central, non-vascularized zone of the medial meniscus. What is the surgeon's most profound concern, and what immediate advice about the future of that joint must be given?
Okay, so the surgeon knows immediately that repair is, well, it's very unlikely to succeed because the tear is deep in that white zone, the non-vascularized part. The profound concern, regardless of whether they excise the tear or not, is the functional failure of the hoop stress mechanism.
So the low spreading is gone.
It's gone. They have to advise the patient that, due to the loss of load dissipation, they face a very high probability of accelerating joint degeneration and likely requiring a joint replacement much earlier than their peers.
And if you listening didn't immediately connect radial tear, non-vascularized zone, and hoop stress,
Please rewind and revisit that first section on meniscal anatomy. It's that important.
excellent. So what is our key takeaway summarizing this paradoxical nature of the knee?
The knee's survival depends on a precarious balance maintained by both static and dynamic structures. Functionally, optimal load bearing is dictated entirely by the mechanical axis, not the anatomical one. And understanding that 5 to 7 degree valgus cut angle in the femur is the difference between a successful, well-aligned knee replacement and one that fails due to concentrated wear.
All right, let's pivot to the consequences of acute trauma. When those static cables of the unstable tower snap, management really pivots on two things. the blood supply, and the patient's demand level. Starting with meniscal tears, we know the patterns are varied.
Indeed. We look at circumferential tears, which can be stable, versus radial, horizontal, or complex flap tears, which are the ones that cause the mechanical symptoms. Diagnosis is usually clinical, but an MRI is essential to delineate the precise tear configuration and, critically, the location.
Why does location matter more than the size of the tear itself?
Because of that vascular supply we talked about. We use a red-red, red-white, and white-white zone classification. Yeah. Tears in the vascularized outer thirds, the red-red zone, have a blood supply and a real chance of healing if you repair them.
But the deeper you go.
The deeper you go into the avascular white zone, they have almost no healing potential. This fact dictates the entire treatment decision. Repair attempts are basically futile if there's no blood supply.
So when do we rush to arthroscopy for a tear?
When the tear is causing mechanical symptoms, a physical catching or locking of the joint, often due to a displaced bucket handle tear, or when it's an acute tear in a young patient that we judge to be repairable. If the knee is locked, that loose tissue is causing acute damage and it needs to be addressed immediately.
Okay, so let's establish that repair checklist. What factors have to align for a surgeon to even attempt a repair rather than just removing the tissue?
You need a young patient, an acute injury, so the tear edges are still fresh. A simple configuration, like a longitudinal tear, and a stable knee, which means no accompanying ACL tear, as instability really increases failure rates. And most importantly, the location has to be in the vascularized outer third. Preservation, even with a long recovery, always trumps excision, if it's at all possible.
And what about those very common degenerate tears, the ones that often present subtly in older patients?
These are often treated conservatively first, as they're really part of the overall wear and tear process. The surgeon has to be cautious here. Arthroscopy for simple debridement of a degenerate tear in an older, stable knee has really fallen out of favor. The evidence shows it provides very little benefit over robust conservative treatment unless there is a clear mechanical issue.
Let's move to the ACL injury. The structural catastrophe of pivoting sports, that audible pop, the immediate hemarthrosis swelling from bleeding, and that feeling of gross instability.
The epidemiological details here are vital for prevention programs. There's a much higher injury risk among females. And the source material attributes this to biomechanical differences, often called the at-risk posture.
What does that mean?
It means reduced knee and hip flexion and increased dynamic valgus collapse, where the knee buckles inward during landing or cutting movements. Smaller anatomical features, like a narrower femoral notch, might also contribute.
And what are the long-term consequences of ACL deficiency? It's not just the instability itself, is it?
No, it's the cascade effect.
Yeah.
Chronic instability places abnormal forces on the menisci and the articular cartilage. This leads to complex meniscal tears and chondral injury or cartilage damage. The ACL-deficient knee is, by definition, an arthritic-prone knee.
Confirmation relies on two crucial clinical tests.
The Lachman test is the most sensitive. It assesses anterior translation with the knee slightly bent, but the pivot shift test is the most specific. It confirms that rotational instability that truly derails the knee's mechanics. MRI confirms the rupture and, just as importantly, identifies those secondary bone bruise patterns and any associated meniscal injuries.
Now, the management strategy. Initial treatment is always non-operative. RICE, physiotherapy, reduction of swelling. When does the conversation switch to surgery?
For anyone with multi-ligament involvement, surgery is mandatory. For an isolated tear, it's required for patients with persistent symptomatic instability, meaning the knee is giving way during daily or sporting activity, and for young, high-demand athletes who simply cannot function conservatively.
This brings us to a really critical point that often causes friction with the patient: timing. Why can't we just operate immediately on that 22-year-old basketball player who wants to get back on the court next week?
Because we are fighting a major complication known as arthrofibrosis, a permanently stiff, painful joint.
It's a disaster.
It's a disaster. Operating on a hot, swollen, irritable knee that has limited range of motion is practically guaranteeing a poor result. We have to wait, often 4 to 8 weeks, until the acute inflammation has subsided, the swelling is gone, and the patient has regained a near full range of motion and good quadriceps control.
And if you don't wait,
the athlete might regain stability, but they could lose 20 or 30 degrees of flexion or extension forever. It's a terrible trade-off.
That's a powerful point about surgical timing. Let's move to the extensor mechanism. So that's the whole unit from the quadriceps muscle through the tendon, the patella tendon, down to the tibia. Ruptures here are high energy, but there are specific risk factors that make the tissue more vulnerable.
Yeah, the source material highlights systemic or local steroid use, which compromises tendon integrity, and also previous open knee surgery, which may have reduced the local blood supply. These compromised tendons can snap during a relatively minor misstep.
The presentation is an absolute red flag, the inability to actively extend the knee against gravity.
And this requires prompt surgical repair or reconstruction. It is a functional disaster if you delay it. The quadriceps muscle belly retracts, the tendon ends separate, and it makes a late repair incredibly difficult. It often requires grafts and leads to persistent power loss.
Okay, let's quickly go back to articular cartilage injury. Since partial thickness defects don't heal, we're focused on full thickness defects, those that go all the way down to the subchondral bone. We noted they heal with inferior fibrocartilage.
Right. So if the injury is acute and includes a piece of bone, an osteochondral injury, the immediate goal is always fixation. Pin that fragment back in place, hope the bone heals. But for delayed or degenerative full-thickness defects, we have a spectrum of repair techniques, depending on the patient's biological age and the defect size.
Let's break down that spectrum from the simplest to the most complex.
The simplest is microfracture. You basically pierce the subchondral bone, which releases pluripotent cells and growth factors from the marrow, encouraging the formation of that fibrocartilage cap. It's cheap, it's a single-stage procedure, but the resulting tissue is weak.
And moving up from there.
Moving up, we have osteochondral autograft transfer, or mosaic plasty. You harvest plugs of bone and hyaline cartilage from a non-weight-bearing area and transplant them into the defect. This is good, but you're limited by the size of the harvest site.
And the most high-tech options like ACI or ACI, which involve cell culture.
These are the high-investment multi-stage procedures. Autologous chondrocyte implantation, or ACI, requires an initial biopsy to harvest healthy cartilage cells, which are then grown in a lab over several weeks. Then you need a second surgery to implant these cultured cells back into the defect, often under a membrane, which is called AIM-ACI.
And the hope is you get better tissue.
The promise is that these cells produce superior hyaline-like cartilage, but the cost, the two surgeries, and the long non-weight-bearing period reserve this for younger, committed patients with large, isolated defects.
All right, let's do another hypothetical scenario. A 40-year-old patient who uses systemic steroids for a chronic condition suffers a sudden painful injury during a jog. They present to the emergency room completely unable to straight leg raise. The knee isn't that swollen. Given the risk factors, what's the most likely diagnosis, and why is this a surgical emergency despite the lack of typical knee swelling?
Okay, the red flags are the steroid use and the inability to actively extend the knee. The most likely diagnosis is a rupture of the extensor mechanism, either the quadriceps or patellar tendon. And it's an emergency not because of swelling, but because the functional gap created by the tendon retraction widens very rapidly.
Muscle pulls back.
The muscle shortens permanently. If surgical repair is delayed, making an adequate functional recovery is nearly impossible. The key takeaway is simple. Inability to actively extend the knee equals surgical emergency.
So our second key takeaway focuses on the nature of soft tissue healing and timing.
Soft tissue success hinges entirely on biological potential. Vascular supply dictates meniscal repair success, and the patient's recovery state dictates successful ACL reconstruction timing. Never rush an ACL, but always rush a ruptured extensor mechanism.
Now we transition from acute trauma to the slow, relentless degenerative cascade of osteoarthritis, or OA. The stats are humbling. It affects over 10% of older adults, and it is definitively more common in women.
And we have to first differentiate primary or idiopathic OA, which tends to affect multiple joints and has a genetic component, from secondary OA. In a surgical context, secondary OA is the focus because it provides a clear, identifiable cause.
So what are those specific events or conditions that lead to secondary OA?
Anything that alters the mechanical environment or damages the cartilage.
Right.
So previous intra-articular fractures that change the joint surface contour, a prior meniscectomy, which we know accelerates the inevitable due to loss of hoop stress, severe ligament injury causing chronic instability, osteonecrosis, which is bone death leading to collapse, or even neuropathic joints like Charcot-arthropathy, where repetitive microtrauma goes unnoticed and leads to destruction.
Let's characterize the clinical features, starting with the pain. How do we differentiate OA pain from, say, inflammatory pain?
It's the classic mechanical pain profile. It's worse with activity, worse with loading, and it generally improves with rest. Crucially, the location matters. If the pain is primarily in the patellofemoral joint, the patient will complain bitterly about specific activities,
Like stairs.
climbing or descending stairs, or that searing pain when trying to rise from a deep chair after sitting for a long period, what we call the movie sign.
And the natural history, the progression of the disease.
It's typically a gradual, steady deterioration over years, but it's punctuated by these short, self-limiting inflammatory flare-ups. In the end stage, the pain progresses from being activity-based to being constant, severe pain that impacts sleep quality and necessitates the use of strong pain medication, ultimately leading to a significant reduction in mobility.
When we examine the patient, what kind of gait do we expect to see, and what does it tell us?
We see an antalgic gait, that's a limp, where the patient consciously minimizes the time spent bearing weight on the painful limb. This short stride on the affected side is a functional response to avoid pain, but it alters mechanics further up the chain, potentially leading to back or hip pain over time.
Let's discuss the physical deformity, which is critical for planning surgery. The default deformity is varus.
Varus means the knee is bowing outward bow-legged. This results from the primary disease process being in the medial compartment, which is the most common site of collapse. Loss of cartilage and bone medially effectively shortens that side of the leg, tilting the knee into varus.
But valgus deformity, knock-kneed, can also happen.
It does occur, yes. It's more commonly associated with rheumatoid arthritis, or in specific cases following lateral compartment collapse, which is much less common.
And beyond alignment, what joint signs confirm the diagnosis clinically?
We look for a bulky joint due to soft tissue thickening and effusions, restricted range of motion, particularly a loss of terminal extension. And perhaps most characteristically, we listen for or feel that palpable and audible crepitus, the grinding sound of opposing rough cartilage and bone rubbing together.
The investigation of choice is simple, plain radiographs. But there's a vital instruction emphasized in the source material about how to take those x-rays.
They absolutely must be weight-bearing. If the patient is lying down, the residual joint space may appear normal, completely masking the collapse that occurs under load. We need a view of the joint under its true mechanical stress.
An MRI?
MRI is useful for early cartilage or soft tissue issues, but it's generally unnecessary when you're planning for established end-stage knee replacement.
When analyzing these weight-bearing films, we look for the 4 radiographic signs.
They are 1. Joint space narrowing, the primary finding. 2. Subcondylar sclerosis, where the bone beneath the worn cartilage becomes dense and white. 3. Osteophytes, which are the bony spurs attempting to increase the joint surface area. And 4. Subchondral cysts, which are fluid-filled lesions that develop in the stressed bone.
Non-operative management is the undisputed first line. We have to address the mechanical load on the joint.
Which means aggressive management of body weight. Weight loss drastically reduces the mechanical pressure on the joint. Coupled with that is regular exercise, critically, to maintain muscle strength and joint mobility. Anti-inflammatories help manage pain, and tools like walking aids or specialized offloader braces can temporarily shift the weight line away from the most painful compartment.
Finally, let's reiterate the caveat regarding intra-articular steroid injections. They are a common request, but the advice is stringent.
They're excellent for dampening down an acute, painful, inflammatory flare-up. They act as a powerful anti-inflammatory. However, they are not a long-term treatment. The source material warns against their chronic use due to concerns about potentially accelerating long-term cartilage degradation and the non-trivial risk of introducing a deep joint infection.
So they're a temporary pause button.
A temporary pause button, not a solution.
Okay, check in. Let's consider a 65-year-old patient with severe chronic rheumatoid arthritis who has painful locking and instability. On a weight-bearing x-ray, you notice severe narrowing of the lateral compartment, while the medial side looks relatively preserved. Which deformity is this patient most likely presenting with?
This patient is most likely presenting with a valgus deformity or knock-kneed, which is more typical of rheumatoid arthritis or lateral compartment collapse.
And what's the difference in surgical planning compared to the default OA patient?
It's a crucial difference. While the default OA patient with varus often requires a high tibial osteotomy or a medial UKR, a patient with valgus collapse often requires specific attention to the lateral soft tissues, releasing the lateral side during a TKR, or potentially a distal femoral osteotomy if they're too young for a replacement.
Got it. So our third key takeaway, summarizing the degenerative cascade.
Knee OA pain is mechanical and activity dependent, diagnosed by classic radiographic signs seen best when the patient is standing. The core treatment philosophy is offloading and mobility maintenance. Weight loss and exercise are paramount, and steroids are restricted to acute flare management, never for chronic use.
Moving into surgical intervention, we differentiate between minimally invasive keyhole procedures, arthroscopy, and open surgery, which include replacements and osteotomies. Arthroscopy is the realm of soft tissue and minor cartilage repair.
The source material lists a wide range of indications for arthroscopy in Table 40.1. It includes meniscal work, ligament reconstruction, removal of loose bodies, and vital emergency procedures like washing out a septic knee.
Let's detail the arthroscopic meniscal procedures. It's usually a day case, but the decision made inside the joint is crucial. Repair versus resection.
Infection is paramount. If the tear is unstable but irreparable, for instance, a degenerate tear in the white zone, we resect the tissue back to a stable rim using shavers and punches. The aim is to eliminate the mechanical catching and locking symptoms while preserving as much functional meniscus as possible.
But the philosophical goal, especially for younger patients with acute injuries, is always preservation. We want to repair those large circumferential tears that cause locking, the so-called bucket handle tears.
Yes, repairing those is critical because they maintain the hoop stress function. The technique involves first freshening the tear edges to stimulate a healing response. Then fixation is achieved using various suture delivery systems, inside out, outside in, or all inside devices, to hold those edges together.
And the price of repair is recovery time.
A successful repair requires the patient to protect that knee rigorously for 6 weeks to 3 months. Restricted weight bearing is crucial to prevent mechanical stress from pulling the newly placed sutures out before biological healing can occur. It's a major commitment, but one that can save the joint from premature arthritis.
The standard for isolated ACL reconstruction is arthroscopic intra-articular reconstruction. We need to create a new ligament and fix it securely. What are the common autograft options and what are the trade-offs?
The two primary autograft options are the bone patellar tendon bone, or BPTB graft, and the 4-strand hamstring tendon graft. BPTB is often considered stronger initially and provides excellent bone-to-bone healing at the tunnel entrances.
But there's a downside.
The downside is donor site morbidity, potential for pain at the patellar tendon harvest site, which can persist.
And the hamstring graft.
The hamstring graft is popular because it generally reduces that anterior knee pain. However, there is a theoretical risk of persistent hamstring weakness, though studies often show good recovery. Once the chosen graft is placed in the bone tunnels, screws or fixation devices hold it in place until the graft biologically incorporates a process we call ligamentization.
The major complication we noted is technical, incorrect tunnel placement.
Absolutely. If the femoral tunnel is drilled too far anteriorly, the graft becomes impinged during flexion, severely limiting the patient's ability to bend the knee and leading to arthrofibrosis or stiffness. This highlights why modern technology like navigation or robotics is increasingly used to ensure precise anatomical placement.
And the timeline for return to sport is long up to a year, with a persistent re-rupture rate.
That year-long timeline is essential for the graft to undergo ligamentization and mature. The re-rupture rate is about 1% per year, which means the athlete must remain vigilant, particularly regarding strength and proprioceptive training.
Let's discuss osteotomy, which is a powerful preservation strategy. The rationale is purely mechanical, correcting malalignment to offload the damaged compartment.
Think of it as adjusting the foundation of the unstable tower to shift the load line. If a varus knee is collapsing on the medial side, we surgically divide the bone, the osteotomy, and realign the axis to shift the mechanical load laterally, pushing the weight line onto the healthier, uninjured lateral compartment.
The most common procedure is the high tibial osteotomy, or HTO, for that varus knee. How is it performed?
It can be done as an opening wedge HTO on the medial side, where a wedge-shaped gap is created and held open with a plate and bone graft, or a closing wedge HTO on the lateral side, where a wedge of bone is removed. The opening wedge medial technique has become more popular because it avoids the need to disrupt the fibula and allows for easier fine-tuning of the correction angle.
And what defines the ideal candidate for this powerful preservation strategy? Because they must be distinctly different from a TKR candidate.
They are young, often under 55 or 60, highly active, and well-motivated to undergo the significant recovery. And crucially, the disease must be strictly limited to one compartment, medial or lateral, and they must have an intact collateral ligament system. We use HTO to buy them 10 to 15 years of good function before a TKR becomes necessary.
Time for another fictional case study. A 45-year-old nurse presents with severe isolated medial compartment OA following a remote meniscectomy. She's active and wants to continue working for at least another 2 decades. She is offered a high tibial osteotomy. Her concern is the recovery time. How would you justify that long, multi-month rehabilitation period for an HDO compared to the faster recovery of a TKR?
The justification centers on biology versus mechanics. While the TKR offers a fast mechanical fix, the HTO is a biological intervention. You're asking the bone, which has been surgically fractured and realigned, to heal in a new position under load. This takes time, typically 3 to 6 months, to achieve solid fusion.
So it's a necessary trade-off.
It's the necessary trade-off for preserving her native joint and avoiding the finite lifespan of an implant right now, allowing her to stay active far longer than a TKR might last.
That distinction between a mechanical fix and biological healing is key. So our fourth takeaway.
Surgical preservation strategies like repair and osteotomy are prioritized for young, active patients with limited disease. Osteotomy specifically targets young individuals with isolated single-compartment disease, leveraging a calculated fracture to shift the load line and slow the degenerative process. The complexity of soft tissue injury management always requires assessing both structure and biology.
When preservation strategies fail or the disease is just too advanced, we move to replacement. The discussion immediately pivots to whether we fix the whole knee or just part of it. The knee has 3 functional compartments: medial, lateral, and patellofemoral.
Right. And if the disease is perfectly isolated to a single compartment, the unicompartmental knee replacement, or UKR, is the preferred targeted fix. But the criteria are strict. Intact cruciate and collateral ligaments, and the fixed deformity must be minimal, generally less than 15 degrees.
What makes the UKR superior functionally, even if the registries show a longevity trade-off?
It preserves the natural knee kinematics. By leaving 2 of the 3 compartments, and critically the ACL and PCL intact, the knee moves and feels much more like a normal knee. Patients report lower complication rates, up to 50% less than TKR, faster recovery, and subjectively superior function and range of motion.
So why isn't everyone getting a UKR? The revision rates on national registries are the elephant in the room.
That's the key challenge. Registries globally show UKR 10-year revision rates are higher, around 6 to 12%, compared to TKR at 2 to 6%. This is generally attributed to 2 factors. 1, the disease can progress into the other 2 compartments, requiring a revision to a TKR.
And the other?
And 2, the UKR is technically far more demanding. Its success is heavily surgeon experience dependent. A small technical error, like a slight malalignment, is poorly tolerated and leads to early failure.
And what about isolated patellofemoral replacement?
It's a niche product, really. Isolated patellofemoral OA is rare. While the procedure addresses anterior knee pain, the revision rate is high, often because the tibiofemoral joints invariably start showing signs of wear later on. Most patients with painful patellofemoral OA are treated with a TKR if they are replacement candidates.
That brings us to the workhorse, the total knee replacement, or TKR. Indicated for bi- or tri-compartmental disease, it's a resurfacing procedure.
And it's important to stress, it is a resurfacing, not a giant transplant. We replace the worn ends of the femur and tibia with metal components and insert a tough polyethylene bearing to articulate between them. It's undeniably one of the most successful interventions in modern medicine for pain relief.
Despite the high success rates, over 95% survival at 15 years, the source material includes a crucial caveat. Patient satisfaction is generally lower than with total hip replacement. Why is that?
The hip is a ball and socket joint that tolerates a high degree of surgical approximation. The knee is a complex, moving asymmetrical hinge that requires simultaneous translational and rotational control. A TKR can restore mechanical alignment and eliminate pain, but often at the cost of the knee feeling different.
How so?
It may lack the last few degrees of natural flexion, or the patient may feel a slight instability or a clicking. That residual difference between a surgically perfect knee and a truly natural knee often contributes to the lower satisfaction ratings.
Okay, let's look at the implant itself. Fixation is usually cemented using polymethylmethylate, PMMA. Why PMMA?
PMMA acts as a grout. It provides immediate fixation by filling the microscopic gaps between the implant base plate and the cancellous bone, allowing for rapid weight bearing postoperatively. It's a proven and reliable interface.
Implant design is categorized by constraint level. Most common are the unconstrained designs, either cruciate retaining, CR, or PCL sacrificing, PS. What drives that decision?
If the posterior cruciate ligament, the PCL, is functional, and the surgeon believes they can balance the soft tissues around it, they may use a CR design, which theoretically maintains better kinematics. However, PS designs are more common, as they replace the function of the PCL with a post and cam mechanism in the implant, which makes soft tissue balancing simpler and more reliable.
When do we step up the constraint level, sacrificing natural motion for stability?
Highly constrained implants are reserved for revision surgery, or cases with severe bone loss or ligament deficiency. The trade-off, however, is mechanical. High constraint increases the force transmitted to the cement-bone interface, which heightens the risk of late aseptic loosening.
And the hinged replacement.
That's the final step, used only when the joint is severely unstable or missing essential supporting structures, as it provides stability entirely independent of the patient's own ligaments.
Modern implants focus heavily on wear reduction to increase longevity. What technologies are key here?
Enhancing the plastic-bearing surface, the polyethylene insert, is the main battleground. We use highly cross-linked polyethylene, sometimes enriched with vitamin E, to increase stability against oxidation and degradation. Ceramicized coatings on the metal components are also used to reduce friction and wear against the plastic.
Let's review the traditional surgical goal, often summarized as a 5-point checklist. It aims for mechanical perfection.
That traditional goal, from Summary Box 40.4, is 1. Correct all fixed deformity. 2. Align the limb precisely to the mechanical axis. 3. Ensure the joint line is perpendicular. 4. Achieve precise collateral ligament balance throughout the range of motion. And 5. Ensure the patella tracks centrally.
But this leads to the most fascinating modern development flagged in the book, the philosophical shift away from strict mechanical axis alignment for everyone.
This is the movement toward kinematic alignment. The traditional approach assumes the neutral mechanical axis is ideal for every single patient. Kinematic alignment, aided by advanced technology like robotics and computer navigation, aims to subtly restore the patient's pre-arthritic alignment.
And the argument is?
The argument is that this individualized position will feel more natural and potentially improve patient satisfaction, addressing that persistent TKR caveat.
This sounds controversial. If you knowingly implant components slightly off the neutral mechanical axis to match the patient's native state, doesn't that risk increased wear?
It absolutely introduces a debate. The long-term data on kinematic alignment isn't as mature as it is for mechanical alignment. Critics worry that by deviating from the perfect mechanical axis, we might compromise the longevity of the implant, accelerating wear patterns in the polyethylene insert, which could lead to an earlier revision.
So precision is everything.
This is why precise execution using robotics is considered essential for KA. You have to be exactly right, or you risk an early failure.
Let's discuss TKR complications. They're classified into intraoperative and postoperative, and the timeline helps us understand the failure mechanism.
Intraoperative risks, besides nerve or vessel damage, are dominated by technical error, implant malposition or malalignment, which instantly leads to chronic instability or stiffness. Patellar tendon avulsion is a dreaded complication during exposure.
Postoperatively, we worry about infection, DVT, PE, and the chronic issues of stiffness and instability. But let's focus on long-term failure, which dictates the revision strategy.
TKR survival is excellent, often over 82% at 20 years. When they fail, the timeline is diagnostic. Early failure, within the first few years, is typically mechanical, so malalignment, instability, or biological, meaning infection.
And late failure, beyond the 10-year mark. This is the domain of aseptic loosening.
Aseptic loosening is usually a consequence of polyethylene wear. The plastic insert sheds microscopic debris, and the body mounts an inflammatory response to this foreign material. This leads to polyethylene-induced osteolysis, the destruction and resorption of bone stock around the implant and the cement mantle, causing the component to gradually loosen and fail.
Revision arthroplasty sounds like a daunting undertaking.
It is significantly more challenging. You're dealing with bone loss from the primary surgery and the osteolysis, often requiring specialized, more complex, and more constrained implants. The complication rate is higher. And most critically, when faced with a failed TKR, the surgeon's absolute first step is a rigorous investigation to exclude infection.
Why is excluding infection so vital?
Because an infected replacement cannot simply be replaced again in one go. If infection is confirmed, it usually necessitates a two-stage procedure: removal of all implants, debridement, insertion of an antibiotic cement spacer, a period of intravenous antibiotics, and only months later, a second surgery to implant the new TKR once the infection is eradicated. It's a massive physical and emotional undertaking for the patient.
Finally, let's discuss knee arthrodesis, or fusion. The book notes this is largely historic and unacceptable to most modern patients as they lose all knee motion.
It is strictly a salvage measure. We reserve it for the most catastrophic failures. multiply revised, chronic joint infections, where all attempts at replacement have failed, often coupled with massive bone loss or irreparable damage to the extensor mechanism. A stable fused leg is better than an infected unstable leg.
Are there any niche primary indications where a patient might jump straight to fusion?
Very rare cases where the patient lacks the neurological control to manage a replacement. If a patient has a severe condition like polio, a major stroke, or Charcot-arthropathy, they may not have the functional muscle strength to prevent a TKR from dislocating or failing. In these instances, fusing the joint ensures lifelong stability, even if it sacrifices mobility.
And if fusion is performed, what is the ideal position, offering the best compromise for function?
The standard ideal position is 7 degrees of valgus and 15 degrees of flexion. This angle provides the best clearance for the foot during swing phase when walking, and the most comfortable compromise for sitting, though sitting does remain difficult.
We've synthesized a massive amount of technical and clinical information, from the hoop stress that saves the joint to the osteolysis that destroys the implant. Let's distill our final summary.
The management of the knee is a spectrum balancing the preservation of native tissue meniscal repair, ACL reconstruction, HTO against replacement like UKR and TKR. The correct surgical path is determined by the extent of damage. Is it isolated or tricompartmental? And the patient's biological age and demand level. And remember that a UKR offers functional superiority, but demands technical perfection from the surgeon to achieve long-term TKR longevity.
That brings us to our final provocative thought for you, the learner, that builds directly on the source material's glimpse into the future. Given that technologies like robotics and computer navigation are increasingly making individualized alignment, kinematic alignment, technically feasible, will the desire to give the patient a knee that feels more natural ultimately overcome the proven, but perhaps less satisfying, long-term survival track record of strict mechanical axis alignment?
And are we entering an era where patient satisfaction starts dictating orthopedic principles, even at the potential cost of earlier revision?
It's the constant battle between mechanical theory and patient experience.
Something for you to deeply consider as you study the future of orthopedics.
That was truly an expansive deep dive into the complexity of the knee joint. We've established the anchors of stability, understood the gravity of poor surgical timing, and analyzed the trade-offs involved in selecting the right preservation or replacement strategy for end-stage arthritis.
Use this discussion to crystallize the concepts, but please return to the full text of Baily and Love. Pay specific attention to the subtle anatomical details, the meniscal attachments, the ligament bundle tightening dynamics, and how the mechanical axis fundamentally underpins all treatment rationale. Keep learning, keep questioning, and keep connecting the anatomy to the pathology.